I'm just going to check if Dr. Ziad is available now, because we can just move on with the next lecture if he is. Just bear
I
with
am
me.
available. Hi, Andrew.
Fantastic. Thank you, Ziad.
No
Nice
worries.
to see your face, even though I only saw you yesterday in the College of Dentistry, so it's nice to see you again. I'll give you an introduction. So this is Professor Ziad Al-Ani. Dr. Al-Ani was awarded his MSc in prosthodontics from Manchester University in 1999. In 2004, he was awarded his doctorate from the same university. The title of his thesis was Studies in Temporomandibular Disorders and Occlusion. He was appointed by Manchester University as a clinical teacher in restorative dentistry in 2004, as well as a research coordinator for the TMD clinic, and is recently a senior lecturer at Glasgow Dental Hospital and School. In 2006, he obtained MFDS from the Royal College of Surgeons in Edinburgh. In recognition of his teaching activities, he was awarded the status of Fellow of Higher Education Academy in 2010. Dr. Al-Ani was one of the 2 finalists in the Teacher of the Year 2006, as awarded by the Dental Defence Union. The award recognised excellence in dental education. He was again a nominee for the 2007 and 2008 Dentist Teacher of the Year Award by the Dental Defence Union after nominations made by undergraduate students at Manchester Dental School. He has published numerous articles on occlusion and TMD in peer-reviewed scientific papers, and he is the author of the book Temporomandibular Disorders, A Problem-Based Approach, and the book Practical Procedures in Dental Occlusion. Today's lecture is on occlusal considerations in anterior restorations. Thank you, Professor Ziad.
Thank you very much, Andrew, and thanks for inviting me to speak at this meeting. I'm well known by my interactive lectures, actually, and I want always the audience to be engaged in the lecture, and I have reasons for that. I'll show that in a minute. Can I ask all the participants if you please can go on this website, polf.com/Ziad745. I want you to vote for a couple of questions or maybe more, just to as an ice-breaking first. And the other thing is some of the seeking opinions about what you're doing at the moment in practice. So please go everybody to this and using your smartphone, polf.com/745, and you should see the following one. You should see something like this one, okay? Right, and just put your actual name, please. Don't put any funny names because I might expose the names. Trust me, I'm joking. This is anonymous. All right, so please just put your actual name in case of if you want you to see your scores or a proof of your attendance as well. That would be good, so we can actually prove that you attended the lectures for your CPD or other things. So I just want to make sure that everybody went to this polf.com/Ziad745 and you already registered your name to be able to vote in this lecture. Okay.
Just to help everyone, I've just popped it into the chat as well so they can copy and paste it. All right.
Thank you very much, Andrew. That's really useful. Thank you. Okay. So yes, copy and paste if you want in your browser. Just put it in normal browser. You should see this. I just had some screenshots of what you may see in your smartphone. Okay. Right, so let's start. Oh, well, already people started. I want you, first of all, just to, put a vote here in which category best describes you here. So some people start already voting. Well done. Okay, getting more. Yeah, I can see more GDPs, general dental practitioners, one specialist. Very good. Okay. Yeah, people are just voting as they register now. I know that's really good. So the system works very well. And I'll show you the reason why I like actually to use this in a lecture like occlusion. Occlusion is a dry topic. People find it sometimes hard to understand or hard to listen to sometimes. It's really, really good to make it interactive. So people are voting already, so that's fine. I know the link is here, guys, still here, and it is in the chat box, posted kindly by Andrew. Okay, I can see a few people voting. So most of them, the GDPs and 2 specialists are getting more voting now. So let's move on. And this is the reason for why I like my Zoom lectures to be interactive, because traditional lectures on Zoom, not terribly impressive anymore. I don't want anybody like this or nodding off in my lecture. So that's the reason for making it interactive. I believe in this. Tell me I forget, show me I remember, involve me I understand. And I like to put the chocolate on the top of the broccoli to make it delicious and to benefit from what's been underneath here. So putting some spices, some flavors on the top of the occlusion topic will make it easy to digest. So we know occlusion, the word occlusion is, by the way, the easiest definition in dentistry, if you want, and it's the most difficult to understand, and everybody believes in that. But because our lecture is about, aesthetics, I tried actually to get some tips related to occlusion in anterior teeth, because when we say occlusion, people always think about the bite, about posterior teeth. But how about the anterior teeth? So look at that. The best restorative and periodontal care will fail with a bad occlusion. And if you don't get into, if you do get into trouble, and understanding the occlusion will generally get you out of it. If you don't understand the occlusion, you won't find an answer for some of the clinical problems. You don't have predictable results in terms of restorative dentistry. So again, don't overlook this very crucial part of examination, which is examining the occlusion. And the occlusion can be a soul-destroying experience. And I know many of my colleagues who had years in practice, they had, or they met patients who actually fed up with, patching up their restorations and keep fracturing again. But the question should be asked here, is the problem in the materials, in the dental materials here, or is something else? There's something else, could be the occlusion as one important factor of causing this catastrophic fail. And you have to remember that occlusion is more than adjusting high occlusal contacts, is more than detecting it with the articulating paper and adjusting it. This is not occlusion. So we need to now think beyond this. We need to go now the extra mile of examining the occlusion to know what could be the factors of causing this fail. So let me put this like a slide in front of you on the screen. And, I just want you to think about what could be the cause of this drifting of upper incisors of this patient, chipped and worn anterior teeth of the other patient, repeated fracturing of class 4 incisor restorations, composite restorations, for example, like previous veneers keep breaking and chipping off. All of this related to, again, anterior teeth and anterior restorations. What could be the reason? Let's vote for that. When occlusal trauma is not evident. I put that because I know that people, you can type in now, guys. I know that some people will say now occlusal trauma. I'm sure that will happen. So occlusal trauma, this is a wide term, but what we mean by occlusal trauma? Is it a high restoration? Is a high, like a restoration not done in a proper occlusion because it's actually raising the bite, or what is the main reason? So let's see what the participants think about that. So just put a couple of words here. What could be the reason for these clinical problems? Let's see if there is any answers. Okay. No responses yet. So people are shy to vote. Just write anything you think is the reason for failure of this. Don't worry, I'm not going to show names, guys. Names not going to be shown here. It's anonymous. I promise. Okay. So no voting yet. Come on, guys. Any votes here? Bruxism. Ah, well done. The first vote here. First brave one. Parafunction, you mean here. Okay. Erosion. Okay, that could be the reason from palatal erosion here, but you can see fracture of the restorations, chipping of like a veneer. Okay, I don't think erosion is the reason here. Parafunction and bruxism, yes, that could be the reason for that. Yeah. Other than that, if say that the patient, we examine the patient is not aware of bruxism, but you know that only 20% of patients, they can tell that they clench and grind their teeth. And we usually know by the partner who couldn't sleep because of the noise of clenching and grinding. But again, we have other methods of detecting, the signs of active bruxism in soft tissues. But say that, we couldn't find any like evidence of parafunction or bruxism. What could be other reasons? But this is very, very sensible answer, okay? Let's see. Guys, there is something called the envelope of movement. So the jaw has like some sort of, different points between centric relation, which is the jaw relationship, the centric occlusion or ICP, intercuspal position, which is this is the teeth relationship. And we can push the jaw forward, we can open maximally. So the jaw has some shape of an envelope, we call it Posselt envelope, and everybody knows about that. And we have here two areas, which is centric occlusion and centric relation. And look at this study by Pamiger, which shows out of 686 contacts, 588 were in centric occlusion and 15 in centric relation. And the other study showed that of 180 swallows, we have 162 tooth contact in centric occlusion and 5 in centric relation. That means this position shouldn't be neglected, the centric relation. So it is jaw relationship. It might not be like within the function, the normal function, but that could be utilized by some patients, as this studies showed. And this studies actually is telemetric registration. So it shows there is an evidence that the use of this jaw relationship. So some people might be actually having some function between centric relation and centric occlusion. So there are some movements, for example. And when you do your occlusal examination, one of the important things which shouldn't be overlooked when you examine the occlusion is to examine the centric occlusion, which is the bite, the habitual bite, the maximum intercuspation, okay, and the centric relation. So you should be able to develop the skill to examine this in order to see the direction of the slide. The reason for that, because if your restorations will change this direction of the slide from centric relation to centric occlusion, or will interfere with this envelope, which I showed you here, okay, this might actually cause some bad effects on the restorations or on the masticatory system itself. So centric relation is a concept, of course, I can't cover it in this lecture, but you need to learn this skill. And we use it in restorative dentistry in different aspects. So let me give you some examples. First of all, in order to adopt the conformative approach, which I mentioned already, that we don't actually want to change this relationship between centric relation and centric occlusion. We don't want to change the slide, for example, okay, in order not that to affect the masticatory system. So we need to keep the envelope of movement as it is for patients when we do simple restorative dentistry. In order to do that, you need to be able to examine the centric relation, examine the slide between the centric relation and intercuspal position before you start your restorative work, and recording it and making sure after you providing your restorations that this wasn't changed. This is the important part in simple restorative dentistry, which we call it conformative approach. Now, when you plan to reorganize the occlusion, when you want to change the OVD, for example, we want to manage a case of tooth surface loss. We don't have now anymore a reproducible position in ICP, in intercuspal position. We don't have a reproducible bite. So we need another reference point, another reproducible, repeatable, reliable 3 Rs position, which is the centric relation, because centric relation is still there, because it is jaw relationship. It's not teeth relationship, teeth are worn down, teeth are gone, I still have another position which I can build up my restorations on, which is called centric relation, and it is reproducible and it is original. I mean, in the patient's envelope, I didn't create any new position. And this is the same position we use when we do complete dentures, of course. When we try to make a stabilization splint to manage a patient with myofascial pain or a patient with a bruxism, or we want to use a splint to test the increase of OVD in advanced restorative dentistry when we manage tooth surface loss, for example, I need again to make this splint in centric relation. So I need to learn how to get and register centric relation. And I highlighted the last one, which is the slide between RCP and ICP could be associated with some occlusive problems in some patients. So these occlusive problems I showed you, I'll come back to it. These occlusive problems shown in this slide actually could be a result of a deflective contact between RCP and ICP. You won't imagine that a problem at the back teeth, for example, causing a problem in anterior teeth, and I'll show you how in the next slides. And this concept of centric relation, by the way, of course, is well known in the field of occlusion. And Peter Dawson, who's one of the pioneers in occlusion around the world, he said this, which I quoted: out of the factors of occlusion, centric relation is the single most important that must be understood by every dentist who works on teeth. And this guy spent his entire life career in occlusion, and he's the founder of Dawson's Academy, of course, in the United States, a well-known academy. And he published this book, which again talks in details about centric relation and the importance of knowing that and the importance of developing the technique of knowing them. So coming back to our main point, the slide between RCP, which is the retruded contact position in centric relation, and between the ICP could be deflective. That means it actually causes an extensive movement of the jaw. And that might be the cause for wear, drifting, mobility, and atypical loss of bone support in the anterior teeth. For example, if you have a patient, when you probe it with the perio probe, you find no perio evident in the other teeth, but there is a big bony pocket around one anterior tooth. You might say this is occlusal trauma, but this is a general term. If we want to know what type of occlusal trauma, of course, we need actually to check that, and checking the contact between RCP and ICP is one of the examinations should be done here. And correcting it actually, most of the cases will reduce the trauma on the anterior tooth. So again, a problem in deflective contact from RCP to ICP causing a problem in the anterior teeth. So we need to check this slide. So we need to learn this technique, how to find, the centric relation, and check this slide, which could be the cause of some anterior teeth tooth surface loss here, and see the slide between RCP and ICP. And assessing the occlusion, of course, it's a full package, guys. It's not only putting the patient, checking the ICP and RCP. You need to get the models articulated in semi-adjustable articulators using a face bow, of course, and we can actually demonstrate all of these movements on the articulator itself. And learning this skill, this is acquired skill, improves with practice. You need to practice that in order to master this centric relation. Okay. So the way of the operators, how the operator is sitting in the chair, the level of for example, the elbows, and the patient's supine position, and how the patient's neck extended slightly, chin pointed upwards. All of these factors are important to get the centric relation found and registered correctly. And even the ways of putting the thumbs and the fingers, we try to manipulate the jaw here. It's called bimanual manipulation. We don't push the jaw, of course. It's like a big topic, the centric relation, as I said. And I mean, there's not a scope of this lecture, but one of the elements you need to master if you want to really to control the occlusion and know the reasons for some failed restorations which are related to occlusion, you need to master the technique of finding centric relation and watching the slide from RCP to ICP, of course. Okay, I want you now, this is, so the first take-home message to learn that you need to examine the occlusion, you need to examine the articulatory system, of course, in general, examining the TMJs, the muscles of mastications and occlusion, and within the occlusal examination, you need to be really competent at finding centric relation and recording it. Now, I want to touch on other factors which might cause problems of the anterior teeth. I want you using your fingertips. Yeah, I've got some now locations here. Just click on the photo, which you think it's like the correct shape of a crown in terms of morphology. So I have participants clicked on this shape. I have now participants clicking on this one here. Okay, let's see who's the winner for this one. Okay, so more clicks on the one on the left-hand side. Okay, few on the right-hand side only. Let's see. Keep on clicking, guys. Okay, more to the left-hand side. Yes, I think, yeah, this makes sense. Look at the palatal aspect of the anterior crown here as opposed to the one here. So we need to consider the palatal aspect carefully when we prepare the crowns, guys, for anterior restorations, because we need to consider the movement of the mandible on this like palatal aspects in protrusion. And this shouldn't be like a slope or thick one, thick palatal surface or cingulum, because that will obstruct the protrusive movement, as you can see here. So the protrusive movement needs to be done smoothly in the correct shape of the like palatal aspect of the anterior tooth. This actually leads us to a concept called the free-dimencentric, which is free-dimencentric. It means that the teeth, when they occlude posteriorly, they should allow slight movement of the cusp tip inside the fossa rather than to be a wedge. So the posterior teeth, when they occlude, the cusp needs to have some room for it to move slightly forward. If you have the tip here, the fossa is pointed, and you have the palatal aspect is thick, this actually will allow no free-dimencentric. And that means we have excessive forces applied on the anterior teeth. So two things you have to remember here. Anterior teeth shouldn't be a thick slope here, should be the correct morphology on the palatal aspect when you restore that, and posterior teeth, which are related to anterior teeth as well, should have a room in the fossa for the free-dimencentric. So free-dimencentric is related to both the posterior and the anterior in order to achieve it, okay? Which is called long-centric sometimes in other books. So again, this will not allow free-dimencentric here, but this one will allow it. So you might do actually some anterior restorations, which they look marvelous. They look absolutely great in terms of the aesthetic, but the patient feels them locked. Locked means they can't have any room of movement there. And with time, you can tell the consequences of that. So again, because of neglecting the palatal aspects of the anterior teeth to be reproduced in the correct morphology, or a problem in restoring posterior teeth when you make the fossa like point fossa. So again, it's not enough only to give some room here. You need to give the correct morphology. The technician can do any crown for you here with a thin layer of porcelain of PFM, but with a wrong morphology. So something like, okay, you look after the labial aspects of the teeth, but how about the palatal aspects of the teeth? So if you don't get the correct forward movement, the correct occlusion here, you will end up with the failed anterior restorations because of the poor morphology of the anterior palatal aspects. Okay, so, and this is quite common. That could be related to lack of ferrule effect, of course, here. But again, ferrule effect, the results of the lack of ferrule effect is more of longitudinal fracture of the root rather than, de-cementing of the post-crown here. So remember, if you go back to our undergraduate knowledge about the preparation of the anterior teeth, you need it to be in two planes here, of course. And guess what? Don't be shy of, or you feel that you're above it, that you use the silicone index. Even with an expert, there is no harm with using this one, which will make a big difference on knowing, that you've got enough preparation and the exact shape with the cingulum and the palatal aspect of the teeth, especially in important teeth like canines. We'll talk about canines as well, why it's very important to reproduce the palatal aspect correctly. So using the correct bare while preparation, using silicone index will help a lot in getting this sorted. Okay, so if you want to get a good function, you need to get a good morphology in your preparation. And if you want to your technician to provide you with the good restoration with the excellent morphology, you need your preparation to be spot on in first place. So always measure the thickness of the temporary. The thickness of the temporary will give you an idea about your preparation and about, that you have enough room and the shape of it as well. Okay, so that's a good opportunity not to be missed here. Freedom and centric, how would you know that if you have a freedom and centric or not? If you have your fingers are cleaned now while you're listening to my lecture, okay, guys, or sanitized, okay, you make sure that your hands are clean. You can put your finger on the labial aspect of the anterior, upper anterior, or upper incisors, and just tap on your back teeth, okay? If you feel any sort of tremor, a jerking movement there and the anterior teeth, that means you don't have a freedom and centric. This is a simple one to test. This is like a not very objective, of course, this is subjective assessment for that, but gives you an idea whether you have freedom and centric or not. Okay, I'm sure now people are testing their teeth and you can tell. Again, this is an example of how to create a freedom and centric by, or helping creating freedom and centric by increasing the width of the fossa. This fossa will allow freedom and centric occlusion, but this one, the pointed one, will not allow it. In terms of implants, for example, this is very important, whether it are anterior implants or posterior implants, you need to reduce the load on them. And, it's always advisable when you have implant supported crown to have a big fossa here to allow some freedom and centric, wider than usual, okay? So about 2 to 3 millimeters platform, with the opposing teeth. So no freedom and centric is described actually as what we call it constricted chewing pattern, or CCP. This restricted envelope of function, it might actually cause some problems or, chipping of the anterior porcelain or, crowns, which is, again, something that needs to be always in mind. So patient with the CCP might present with chipped, worn anterior teeth and sometimes TMJ symptoms. You have to be careful about the relationship between like the TMJ or TMD and occlusion. I wrote a review article about that published last year in Journal of Primary Dental Care about this, and this is still not supported by evidence, that any occlusive problems might cause a TMD. So I have to be careful about that. But here we're talking about the restorations. So something like that, these meant to be palatal aspects of the teeth. Of course, they should look like a labial aspects of the teeth. You can actually warn them two faces there. So again, especially in patients class 2, DEF2, the skeletal pattern is important as well here. Bulky cingulums, all of these will cause this constricted chewing pattern. How would you examine it more precisely than tapping on your back teeth and putting the finger on the labial aspects I showed you? You can use what you call the secret of success in occlusion, which is shim stock foil. Okay, shim stock foil. I'm going to talk about it in a minute in a little bit of details and how or the advantages of using it. So what we do, we can ask the patient to sit upright here and close the teeth together, putting the shim stock foil held by Miller's forceps here, as you can see. And then the patient can actually, catch the shim stock between the teeth there, so we can't pull it through. And then we change the patient's head position, so tilt it backwards, and we'll see if the shim stock is still held between the teeth. This patient has this contracted chewing pattern or the no freedom and centric, because even changing the position of the condyles didn't change the contact point here. So the patient have a very close contact between the anterior teeth in other terms. So shim stock foil, you can, I'm sure many of my colleagues, they know it. It's 8 microns foil. It has many advantages. So let me see how many of you using shim stock foil, guys. If you can vote for that, do you use shim stock foil? Yes or no? Okay, so getting some votes here, almost 50-50. Okay, so people who are voting here, we have the vast majority not using this shim stock foil. This is one of the take-home messages, guys, from my brief lecture today, is to get that in your drawer for occlusal examination. It is very useful. Foil it's versatile, has multiple use in dental practice. Let me show you some of the use of that. It is actually a feeler gauge. This is the definition of the shim stock. So usually we use it in practice to check whether these restorations, they have occlusion or they are infra-occluded. You see what I mean? Because 8 microns thickness there. It doesn't have ink, of course. It doesn't mark the teeth. So the importance of that, you can actually check whether the articulation of models are correct or not. Because when you take impressions for study models and you pour them with the stone and cast, and you put them in articulator and you put the bite registration material, sometimes there are potential errors there in the articulation. So you have an 8 microns gauge. So if you put this 8 microns between the patient's teeth, all right, and then record that, for example, the upper 6 with the lower 6, they hold the shim stock. The upper 4, it doesn't hold the shim stock because there's a little bit of gap. This is the patient's occlusion. And you can ask the technician or yourself, if you have your articulated models on the articulator, to check by putting the shim stock between the stone, between the study models, okay? And then check whether it's the same clinically. That means your articulation is spot on. Okay, and vice versa. So if, for example, your clinical record showing that upper 6 with the lower 6, they are catching the shim stock here, but on the lab, it's pulled through, that means there is a problem in the articulation. As simple as that. Okay, so you have an accuracy down to 8 microns with that. The other advantage of using it, this is something, you know, in field of occlusion, guys, most of it, it's not evidence-based. Let's talk about the facts there. There are some suggestions from experience, okay, but we don't have like evidence-based studies to show it is a must to use this protocol, for example, or not, in most of the aspects of occlusion. But one of the things which is advisable, let's say, rather than a protocol, is to, when you do implants dentistry, you should have some sort of clearance. It was about 30 microns between the implant-supported prosthesis or crown and, again, the opposing teeth. In order to do that, how would you gauge these 30 microns? We have 8 microns thickness of the shim stock. So if we fold it to 4 layers there, 4 layers should be grip between the teeth there, but 3 layers should be pulled through. You see what I mean? That means there is a clearance by 30 microns. It doesn't need, you know, extensive math skills to figure this out. So again, yes, we can use it to estimate how much clearance we want. One of the things introduced by this company, you know, which will be very helpful, because somebody might ask, how would I compare the clinical findings of shim stock hold with the lab? You can get this sheet. I'm happy to post it for you. It's available on the web, I'm sure. And it's called shim stock hold. It's very simple sheet, can be used easily. So you can actually put marks, for example, between 1-1 and 4-1. Is the shim stock held between these teeth? Put yes or no. Again, between 1-6 and 4-6, we found it held, put yes. And then send this to the, over to the technician. The technician will compare it with the cast and will make sure that the articulation was absolutely spot on, correct. Okay, so again, a sheet like this one, simple one, can facilitate the communication between you and the technician regarding the accuracy of articulation. So coming back to the management of the constricted chewing pattern I showed you, we said that, okay, the patient doesn't have freedom in centric, and you provide the patient with some composite restorations, for example, anterior teeth. So if the patient has this strong bite anteriorly, so there is no freedom in centric, let's say, you need to do something about giving some sort of easing of this area. If we use thin articulating paper, you might actually remove some of the occlusal contacts and create a gap between the teeth. We don't want infra-occluded restorations, guys. This will cause over eruption and will cause disturbance of the occlusion of the patient. Unless we do something like DAL concept, which is completely different there, you know, when you leave some gaps in posterior teeth, this is monitored, okay? But again, coming back to this one, so use 200 microns articulating papers and ask the patient to chew on that and get some marks there. These are marked by 200 microns. Easing this one until you don't have marks, and use this thin articulated paper, which is 40, you should have some marks there. So this will create some room in anterior teeth and reduce the load on them in case of the CCP, as we said, okay? So this is something to avoid as a preventive measure, to avoid problems in your anterior restorations in a patient with a CCP or lack of freedom in centric. Remember, guys, other things which is very important. When we talk about anterior teeth, we have canines as well. When you involve your canines in restorations, you have to be extremely careful about not disturbing the pre-existing occlusal scheme. If the patient has canine guidance, for example, I don't want to create an interference. I need to keep this guidance, okay? If the patient has group function, I need to keep this group function. I'm talking about simple restorative dentistry to conformative approach. So that's why, extensive care should be put there to reproduce the palatal aspects of the canines. You remember palatal aspects of the canines, they're not bulky, they're not like a slope. That we have a ridge, we have two fossa or slopes there. So this is actually there for a purpose, because the canine guidance could be on expense of one of these slopes. If you make it bulky, if you make it like a belly shape there, that will obstruct the movement of the jaw and will actually lock the teeth in the lateral extensions. And we see a lot of problems with, unfortunately, full mouth, porcelain, full mouth rehabilitation with porcelain crowns or veneers, whatever. And the patient, okay, was over the moon after receiving this because it's marvelous aesthetics, but as simple as that, they can't move the jaw, it's locked. Those patients who have remunitory chewing pattern, they will not be able to do that. They will not be able to actually slide the jaw right or left because you actually obstructed it with the poor morphology of the canine, something like that, bulky palatal surface. Okay, so again, this won't help. This is not the palatal aspect of the canine, something like that reasonably, okay? So look after that. The poor morphology will end up with poor guidance. So the patient will not be able to make lateral extensions with the good guidance. So most of these restorations will be replaced not only for the aesthetic reason because they're not good, but sometimes they're aesthetically acceptable, as I said, but functionally they're not. So you have to look after this area when you do the palatal preparation of the canine, of course. So good prep, good morphology of restoration, better knowledge of tooth morphology can help to optimize that. So that case actually needed to be redone with new wax up. The wax up using semi-adjustable articulator should, of course, achieve this lateral movement with the canine guidance or groove function, and by looking after the shapes of the upper and lower canines, either palatal aspects or the labial aspects of the lower canines here, to achieve this disclusion in the lateral exertions. Whether you use a digital system or using traditional way is the same thing. The same principles have to be applied in looking after the morphology of the anterior teeth and especially the canines. This is a case published in BDJ a long time ago, which showed the patient couldn't tolerate this bridge, and the problem was the bulky palatal surface of the canine. The first thing you do here, guys, before replacing the existing bridge with a brand new one, get the temporary. And on the temporary, try to achieve some guidance here on the teeth once patient is happy with that, and most of the cases patient will be absolutely satisfied by having a guidance there, you can actually copy that in your final restorations. Okay. The other thing is to consider the protrusive movements as well. The protrusive movements, when you have like a class 4 restoration or you have a veneer, make sure if you have guidance on adjacent teeth, on a sound tooth in protrusive movement, you don't need contact and protrusive movement of the restoration, as long as there is a sound tooth which can actually ensure the guidance there. So if this tooth can ensure a protrusive guidance, you don't need a contact on your restoration. So that will save you troubles, possible troubles of that. Especially if you have thin veneers, you need to avoid the guidance on them. And when you have veneers like that, try to get the occlusal contacts mainly, not on interface, of course, between the restoration and the tooth. Try to get the occlusal contact in the sound tooth, and the guidance, if you can avoid it, if there is like adjacent tooth, which is natural, make it on expense of that tooth. The last point I want to mention here, guys, about, we're talking about the importance of the palatal aspects of the anterior teeth, okay, in terms of the guidance, the protrusive movements. So when you prepare the teeth, if you prepare multiple anterior teeth, eventually you're gonna end up with losing the shape or the morphology of the palatal aspects because you prepare them. So you send the technician the impression, and they've got the cast and everything, and try to wax up these restorations. So they wax them up, okay, could be like a nice wax up in the palatal aspects, but it is not the same morphology exactly like the one before preparation. I think you got the point, okay? So we're losing here a guide. So if you prepare the teeth, I don't have an adjacent tooth which shows me the shape of the palatal teeth for this specific patient. That might differ between patients. So what would you do? It's advisable in these cases is what you do is the technique one is to do what we call the crown about method. This is a modified photo just to explain what I want to say. It's crown about method that you do every other tooth. So prepare one tooth, leave one. Don't do them at one go. Okay, this will cost you and the patient an extra visit, but that will help the technician in waxing up the palatal aspect of this tooth by looking at the adjacent tooth still there. You see what I mean? And then when you fit the crown here, you can get, the technician can get the morphology from the crown, which is already in place. Somebody might say, oh, how about the shade? Shade, of course, you're selecting the shade carefully, and the technicians using the same system. There is no here any sort of concerns about making another visit and copying the same shade. That's not a problem at all. But you need here 2 impressions, of course, and you need more than 1 visit. But that will ensure the palatal aspects is being reproduced exactly like the teeth before preparation. So we can actually, as I said, sorry, just move this one. Okay, okay. Let me just move this one, sorry. Yes, so now the other technique, so that one, when you have teeth, you need to prepare. The other technique, when you have tooth surface loss like this one, so you don't have originally any sort of morphology of the teeth, and you need to crown these teeth of the posterior, for example, the definitive, including the posterior teeth, the definitive treatment is like crowns on the anterior teeth. Get the temporary right. So once you get the temporary right, what you do, make sure that the patient, of course, using the accurate impression, the face bow, and you articulated them, and the semi-adjustable articulator, you've done the wax up, and you fabricated the temporary. So these are the stages. Make sure when you do the temporary, okay, that you get the occlusion in static and dynamic occlusion, right, in terms of the guidance. So we'll spend some time, adjusting the palatal aspects of the temporary until you get the guidance, of course, between posterior and anterior teeth. And then you now satisfied, of course, I just mentioned that the temporary restorations here, although we tell them temporary, call them temporary, it's more than temporary, they are provisional. The reason for that, because it's not only a cap to, cover the tooth, it's actually testing the tolerance of these restorations and the OVD and the occlusal scheme which we produce. So it's more than a temporary I like this article by Professor Trevor Berg, long time ago, it's 2005, which is saying that the provision is not just a temporary, talking about the provisional crowns. So get yourself a good material of the provisional crowns in order to test the occlusal scheme as well. So once you get that, now the temporary is ready, and it's actually done according to a good occlusion, because you spend time testing the static occlusion, the lateral exertions, you adjusted them until you got the canine guidance or group functions sorted. Now I'm going to do the definitive restoration. So how would I copy the palatal aspects of the temporary, which is already in good occlusion, in my definitive restorations? Okay, so first of all, we need to check that there's no fracture, everything. If there is any fracture or mobility or sensitivity or cement failure or discomfort or drifting, that means the patient is not tolerating, of course, the occlusal scheme or the increase of OVD, if there is increase of OVD. So that's, of course, it is, sorted already. Now I want to copy the palatal aspects of that, which are in a good occlusion. In restorative dentistry, there is, after, for example, you've got the occlusion right here, you've got canine guidance, there's no canine here, so the medial aspect of the premolar took the guidance, so it's a perfect palatal aspect. I want to copy it in my definitive restorations. So we take the impressions, we take a face pull, of course, and we request what it's, let me show you that, or what's called copying anterior guidance. Copying the anterior guidance is a well-known procedure in restorative dentistry to actually copy the shape of the palatal aspects of the, especially of the temporaries, in the lab. So how would you do that? You get a little bit of a duralay, the duralay, if everybody knows the duralay, which is self-cured acrylic material, basically. And it's the advantage of using it gives you good working time. You get it like a dough, right? So on the semi-adjustable articulator, that's in the lab. So you have here, pay attention to this, guys. This is an impression, and this a cast of the temporaries, of the provisionals. So we took an impression of the temporaries or the provisionals, and we have a cast here. We articulated them. The dough here is soft. So what we do in articulator, we try to move the articulator forward. We move it to the lateral side, right-hand side, left-hand side, lateral exertions. We do all the dynamic movements. The incisal pen here and the articulator now is going to create a shape inside the dough itself, inside the duralay. And this shape is based on how the lower moving on the upper is the opposite in the articulator, of course, based on the shape of the temporary from inside, because, this will create a shape which looks like the palatal aspects of the temporary, because the movement is done by the temporaries here. So have something like that on the table itself. So what we do now, look at that. This is the, again, a close up. This is the temporary, okay? This is the provisionals, and moving now them on the articulator, we created a shape here. So let's show that in this illustration. So these are the temporaries moving. Look at that. The shape created here looks like the shape of the palatal aspects here, because that's exactly how the jaw is moving on this particular patient. Now we have we remove the temporaries from the articulator. We get the prepared teeth, and the prepared teeth now is gonna be waxed up. The wax should actually make the same movement here, and the guide for us is this template here. So say, for example, we wax it up this way, right? And we try to move, the jaw is not moving. We carve it, remove it from it until this movement happening here. So this shape here of the template will guide us to the shape of the palatal aspect. So by doing that, we copied the palatal aspects of the temporaries, which were done in a patient's mouth with a good occlusion. Maybe it's difficult to explain it sometimes, in slides. When I show you a video, we can do that in our teaching in the college. We show videos and we demonstrate that in the lab as well. But let me show you that, that the pen can move from this side to the side. This actually was soft, so created a shape here, the same one we use it when we create the final restoration. So you can see here, after waxing up, you can see that the shape is created here, and there is a smooth movement inside it. That means the palatal aspects of the anterior teeth is the same like the professionals. I think we can stop here, but before that, most of the procedures, we put them together in a book, which is published already now. The hard copy is going to be on shelves in November. You can actually order the pre-order already now of a book called Practical Procedures in Dental Occlusion. Where my good friend Ziad, myself, in the quarantine, actually, we had a good chance to do some Zoom meetings actually to finalize this book, which is a book targeting general dental practitioners for in the subject of occlusion, and it's mainly practical procedures. So we try not to touch in details in the theory, but to make it like practical. And there is like a link for videos in a website. When you purchase the book, you can access to see all the practical procedures in the videos. So thank you very much for your listening, and I am happy to answer any questions if you have.
Thank you, Ziad. If anybody has any questions, can they pop it in the chat window, and then Ziad can have a read and answer them for you.
Okay. Okay, so thank you. I can't see any questions. Okay. So far, there is no questions. Okay.
Okay, I think got some thank yous coming in. So thank you very much, Professor Ziad. I don't think we've got any questions from you. But if anybody doesn't have any questions, they can contact the Knightsbridge Dental Care and send it to the email address info@kbac.uk. So Knightsbridge Academy.
Yes, I'm happy to see that, you know, the reason for silence is a clear presentation. It's not the opposite.
Absolutely. Everybody obviously understood everything, and you've, thank you very much. So thank you, Ziad. You can sign off now. Just want to check if Raj, are you with us and are you ready? If you're
I hope so. I hope you can see me as well.
I can see you and hear you clearly. So
excellent.
It's my pleasure to introduce Professor Rayan, OBE. Rayan is Professor and Head of Restorative Dentistry at the College of Medicine and Dentistry. He was past Dean at the Royal College of Surgeons in England and responsible for postgraduate dentistry for London as Associate Dean at the London Medical and Dental Deanery. He has delivered over 1,000 international lectures and has helped change continuing professional development in the UK. He was an advisor to the Secretary of State for Health, one of the three wise men to the Lord Chancellor on appointments of magistrates and judges, and a member of the General Dental Council. He was made an Officer of the Order of the British Empire by Her Majesty the Queen for his services to dentistry. I'm pleased to announce he's presenting on aesthetics and ethics. Is it a paradigm shift? Thank you, Raj.
Thank you very much, Andrew. Looks like I've got a lot more time to spend with you, if you so wish to have that time spent with me.
By all means, Raj.
Thank you. As head of restorative dentistry, I can't tell you how delighted I am to have Professor Shamir Mehta, Professor Ziad Al-Ani, and Professor Wyman Chan in my department. They are a great strength to our College of Medicine and Dentistry. And from the lectures that you have heard from them, you can see that there is a steep learning curve you can meet if you have your minds open. My lecture, because I'm head of department, can be more challenging, and therefore they gave me this topic, aesthetics and ethics. Is there a paradigm shift effectively? And I thought I'd share with you what is happening in the Western world and how it might affect you as well. because all lands come to the same pathway sooner or later. Of course, these are some advertisements from dental practices, and I envy them because I was in Harley Street in a referral-only practice, and I did not even have a business card. All my patients came in purely because my colleagues referred them, not because patients referred them, because colleagues referred them. And the one advantage of having a practice, which is a tertiary care practice, doing full mouth reconstructions and colleagues referring patients to you, is they don't usually complain about your bill. So anyway, other practices are not quite so fortunate, and they do have to advertise. And here's a very nice advertisement I have seen. And there's another one, even nicer, dedicated to creating beautiful smiles. And then, of course, your smile is our vision. But the question I need to ask is, yes, who is it? Who is it that does not do good teeth? Which practice does ugly teeth? Why is all this marketing so important, especially when you have so many other colleagues doing exactly the same thing you are? Or are they, is the question one needs to ask. So this is about practices which are marketing. The next question I need to ask also is the dentists themselves. In the UK, we are very strictly regulated, less strictly now than we used to be regulated. So in those days, we could never advertise. Now we can advertise, but it is unusual, probably unexpected, for a dentist in the UK to call themselves the best cosmetic dentist. Even more unusual to be able to advertise as the best cosmetic dentist in a certain town. I mean, looking at this, I'm sure she probably is the best cosmetic dentist in Houston. But when you look at the qualifications, it's about the basic dental qualification anybody could ever have to do dentistry in any country. So with a box standard qualification, to call yourself a best cosmetic dentist, well, it takes a lot of courage. And I admire the courage of some people. And I wish I could be as courageous as some of the people who market. So I actually looked at more American websites. Yes, because I wanted to answer the question, what makes you the best? Whereas some people did not have any credentialing as to what makes them the best. Some people do. So for example, there's a Lux list of modern luxury. The winner here was a chap called Peter Boulden. And that means somebody else has credentialed him. But of course, what does a Lux list mean? Lux list has the best sommelier, that's wine people, the best chef, the best haute couture maker, the best dressmaker, all that kind of stuff. So, and the credentialing of this gentleman is that he's the distinction of being a fellow of the Academy of Comprehensive Aesthetics, now part of the Smile Source Network. And I thought, what on earth is that? In any case, I looked into this person because it was very admirable. I mean, I was envious of the position that this person had. And I found he also did a course on bulletproof mentality. What is a bulletproof mentality? Usually you have a bulletproof car when somebody's trying to shoot you. So why do you need a bulletproof mentality? And looking even further, I found another course, which was dealing with upset patients. Oops. Then when I looked at the credentials, I saw there was more than just the basic dental qualifications. There was a fellow of something, fellow of another thing, fellow of other things, and fellow of more things. And then I went in and looked to see what these fellowships were. And these fellowships are really based on a lot of societies where people get together and create a club and give each other fellowships. One or two of them actually, you have to answer a question paper and pass. But by and large, most of them are credentialed by being a thoroughly good person or knowing someone who has a good contact. Nevertheless, aesthetic dentistry is very important. Where would Tom Cruise be without getting his teeth fixed? I mean, so many actors, so many personalities, so many politicians, so many royalty, and I should know, I treated a lot of them, want to have nicer teeth because they are projecting their personality and their aesthetic appeal. So where does it all leave us? I looked at the Lux list again because I was curious about this Lux list. And in fact, in 2019, the same year the other gentleman was on the Lux list was another dentist called Dr. Alan Malouf. And one thing I loved about him was that he assisted patients with odd hours of dental emergencies. and also came through on the social front, giving patients tickets to 80 San Francisco Giants baseball games per year. Wow. If that doesn't get you good patients, I'm not sure what will. But sadly, the poor gentleman passed away that same year. But his sister said, and he was a dapper dentist, so in other words, he dressed extremely well. But his sister said, where he would be with Patty Hearst, Jane Fonda, Ariana Huffington, Prince Charles, I mean, he was a man with the stars. So does that make a good dentist, was the question. So the key question for the first part of this lecture is, what makes a good dentist? And having been a very long time in dentistry and in extremely successful practice, and having given over 1,000 international lectures and produced papers and changed a lot of the way dentistry is taught and examined in the UK, I came to the conclusion that being a good dentist, you need good contacts, because good contacts make a big difference. Yes, because people come already trusting you. Good marketing is very useful because good marketing adds to the feel-good factor of your staff, not just your staff, but also your patients, because they think that you are somebody important. A good personality is extremely helpful, especially when you come to cosmetic dentistry, because cosmetic dentistry is absolutely filled with patients with different perceptions to you. And if you can get on with them, you can convince them, you can discuss with them, you can empathize with them, and they can empathize with you, your work will be much better than if you just produce good work alone. The emotional, intellectual quotient, the connection becomes so important. So a good personality, a gentle, kind personality, all makes a difference. Good clinical dentistry is very useful. I've seen lots of extremely successful patients, dentists, whose patients I've had to reconstruct. So being very successful and very profitable and very wealthy does not necessarily mean you do good clinical dentistry. In fact, there are some very famous names, dentist work I've had to rechange. But having said that, if you did good clinical dentistry, it's more than a bonus, because then others, your colleagues, will realize how good you really are. And finally, good peer-reviewed credentials. Good peer-reviewed credentials, I think if you're on your pathway to proving yourself in this world and you're starting out, is extremely helpful. Having additional proper qualifications, not by the post fellowships, but real, structured, peer-reviewed education, it all becomes important. But you could make a very good living, a very good life, and be a fantastic dentist with any of the above, but I would think that you would prefer to do it with all of the above. And that's really why we have this College of Medicine and Dentistry, and Professor Al-Mazri is very keen on young people with open innovation, challenging minds. We love to be challenged. We do not teach you like an undergraduate establishment or an undergraduate school, which is now postgraduate produced. We are mostly clinicians. We've been there. We've learned from our mistakes. It's from our hindsight that we have generated our insight. And we will teach you. I mean, the field of occlusion is built on lies about lies about lies about lies. There's hardly any evidence in most of dentistry. Much of the evidence is based on your experiential learning. And of that, we have plenty. And we will challenge you, and we will expect you to challenge us as well. Now, let me challenge you on this. What is this? Is this cosmetic dentistry? Do you think this is cosmetic dentistry? What about this patient? This patient turning out to be this. Is this cosmetic dentistry is my key question. Is this what you look at and think, wow, I wish I could do this? Who matters in this work? Who is the person who did this cosmetic dentistry? That is the key question. Whose work are you showing? Because the illusion needs an illusionist. To change a mouth from what it was to what it is, you need someone who is exceptional, who does that work. Is it the dental technician in the work I have shown you? The answer, I'm afraid, is not. It's got nothing to do with the dental technician. It's to do with the IT consultant. That was to do with my son, who is an illustrator and animator. And he works a lot with Photoshop. But I can definitely confirm to you that my work isn't Photoshop. My work is real, honest work. They're on analog slides. Beware of international speakers, Mr. Howdy Doody, who come and sell you their beautiful dentistry. I can almost guarantee, because I have given lectures right across the world. You name a country, I've been there. And after our lectures, we sit at the bar and we have a drink and we have a natter and we have a laugh. And by and large, I can tell you, you are seeing touched up photographs. Yes, Adobe Photoshop is fantastic. When you finished our course, go and buy this. Maybe you might have to adjust one or two of your work. You see, Photoshop teeth. How, you have to take a double look to see that they have been Photoshopped. The art of this is phenomenal. Beware of lectures on cosmetic dentistry. Yes, the art of deception. What you see is not what you get. So I would say, don't despair about your work. Yours is real dentistry. And if you're honest about your real dentistry, we can teach you to make it amazing and exceptional. So what about dentistry and aesthetics? What is beauty? Beauty is truth. Truth is beauty. That's Keats, our great poet. Anatole of France said it was more profound than truth itself. Yes. The Symmetry of a Beautiful Face by Stéphane Marcotte, of a plastic surgeon. So to get this beauty, most people say, oh, I use the golden ratio. Now, what is this golden ratio? Whatever it is, I can tell you it is the position from which you look at. You can create a golden ratio for anything as long as you're willing to turn your head in any one direction. In fact, the science says it's rubbish. It doesn't affect teeth. It doesn't apply to teeth. So a lot of the stuff that you go back on and you look at and you were taught, and people wax lyrical, is all lies. It's more con after more con. The problem with aesthetics is, as a human being, the dentist can see more than 3 to 5 million colors, but we don't have the vocabulary to describe it. And some people are better able to translate it than others. Certainly women are known scientifically to be better than men. So my nurse always helps, and luckily for me, in my practice, my technician was. We both work together in the same building. And the responsibility is well passed on to your technician. And I need help in the form of a background support. And if you're looking at a shade for more than 5 seconds, your rods and cones have already tired out and you get the wrong feedback. So 5 seconds is the maximum time you have to make a decision on a shade. Otherwise, you've got to go away and come back again. And shade taking is extraordinary. It's all about lighting conditions. Now, the lighting conditions in the UK is different to your lighting conditions in Dubai or in Turkey. Our lights are northern lights. We do not take our shade taking in daylight. We need a bluer light source for British patients. So it is different. And remember, your visual acuity is just 5 seconds. 5 seconds and it moves on. And of course, some people are colorblind. You need to check on color blindness. And of course, a large percentage, 40% of males have some degree of color blindness. That's why women are better than. And after 15 seconds, definitely all your receptors tire. So, and also shade guides, they're rubbish. Let's look at the Vita shade guide. Why is it that the world has Vita shade guide? The reason the Vita shade guide is worldwide and used by all of us is that when I graduated as an undergraduate, long before many of you were born, is that they gave all dentists a free Vita shade guide. The reason every dentist got a free Vita shade guide, because dentists are mean people. We don't want to spend money if we can help it. The reason we got a free Vita shade guide was because Vita then knew if we prescribed a Vita shade A2 or A3 or whatever, The technician then had to go and buy the Vita porcelains. Brilliant, wasn't it? Brilliant. Yes, manufacture a car, give the car free, but let it run on a particular type of petrol, which nobody else has. You made your fortune. And the Vita shade guide is rubbish because the way it is arranged, A1, A2, A3, A4, is nothing to do with teeth. Teeth are about value. That's why composites are so brilliant. Composites are metameric. Metameric means they can disappear into the mouth. That's why acrylic dentures look fantastic, even if you get the shade wrong. You have 5 shades for acrylic dentures. They all look good in anybody's mouth. Porcelains, you have to really work hard because they are not metameric. You have to build them in. All because their values are not as phenomenal as acrylics. So composites' greatest success is because it's made of acrylic, methyl methacrylate. Yes, bis-GMA, bisphenol A, glycidyl methacrylate, UDMA, divoclar product, urethane dimethacrylate, even adhesives, 4-meta, methacryloxyethyl trimelylate anhydrate. Everything is a methyl methacrylate with a bit of epoxy resin, a whole lot of fillers thrown in to reduce the shrinkage, and voila, you have a material that blends in the mouth. The only reason it looks bad is because you don't know how to use it, and we will teach you how to use it. There are small secrets that make big differences. You don't have to spend more than 10 minutes to make a beautiful aesthetic posterior composite filling. I mean, the preparation takes time, the adhesion takes time, the first layer takes time, but the aesthetic finish, we don't use burrs at all. Teach you how to do it. Looks like $1 million. Nobody will even know that these are composite teeth. And they are great because they are metameric. They disappear into the mouth. Most of the time, dentists get it wrong because they don't know how to make it disappear into the mouth, because these materials want to disappear into the mouth. So if you have a Vita shade guide, please rearrange your shades. You'll find life so much easier. Start with the B1 first, because this is on value basis. You'll find your shade taking improves so many %. And now you'll find the modern Vita shade guides and all based on values. But in any case, what is aesthetic? I mean, the Mayans thought this was aesthetic. In this century, I mean, I've lectured in Kazakhstan and other countries, and dentists have shown me some of the teeth of some of their local communities, their local tribes people. And for them, getting teeth like this is aesthetic, not our concept of aesthetic. Concept of aesthetics is unique to that individual, to that culture, to their upbringing, to that nation, amongst lots of other things. So this is that plastic surgeon's patient. Is she beautiful? Is she beautiful? Or is she beautiful? It's the same patient, same width. All I've done is elongated it. Beauty is in the eye of the beholder. So by and large, if you can speak to the coconut of the patient, if the patient is convinced about you, a lot of your aesthetic dentistry becomes so much more easy. But if you have a patient who has personality problems, who really look like the back end of a horse, yes, who are trouble or waiting for trouble, you ain't going to get it right. These people with body dysmorphic disorders, amongst other things, will always be a cause of problem. It's a mental problem. You really don't want to practice with mental patients. You know, there are 7.5 billion people out there, more than enough for each and every one of us. In the UK, we are crying for dentists. We don't have enough dentists to fix cases. Huh? Remember, you don't have to treat everyone, because there is always somebody out there who wants to treat everyone. Let them treat it. You don't be a fool. Let's show you some other bits. It'll dovetail into the lectures of my 2 other colleagues or 3 other colleagues, yes, of today. So this is a patient who came in to see me, and he was getting on a bit in age, but he was being honored by Her Majesty the Queen, just as I have. I'm grateful for that. And he was going to give a speech on a very important occasion. And of course, patients like this, very easy. It's a 15-minute makeover. You don't use a burr on these patients. You use a scalpel, You use your composites, any shade, the shades you never use on real composite cases, because you're going to do a trial composite run on this patient. So you just pop on a bit of composite. Yes, you pat it in with the back end of a scalpel. You get the nurse to zap it for 5 seconds, 2 seconds, 1 second, and then you shave it with your scalpel blade, and you just keep adding it. You just keep adding it and you shave it off. No acid etch. You just flick it on the teeth and you tell the patient, is this what you want to look like? Yes, that's on the first visit. You've had your consultation, you've done your exam, or the whole lot, and then for 10 minutes, 15 minutes, you just walked it, because you know you can whip it off if the patient didn't like it. And you ask the patient, and you tell, take it home and try it out. Take it home and try it out. And the patient takes it home and tries it out. And usually nobody ever notices, because people at home, which is their family, love the people who are in their family. They don't notice little things like this. Usually when I do a full mouth reconstruction, and my practice was based on the foundation of full mouth reconstructions, I ask a patient after I've cemented it in provisionally, what did your family think? If a patient said they thought it was wonderful, I'll take it off and do it again. Because reconstructions, aesthetic dentistry should never be noticeable. If it is noticeable, there is something to be noticed. It is different. So a patient goes back, nobody's noticed it. What happens? Within 24 hours, 48 hours, 3 days, it all starts falling off. Bits fracture off. That's when you make your sale. When bits fracture off, it looks so horrendous, the whole family realizes how terrible the teeth were. Yeah, when it falls out, that is when the difference is noticed. But what have you forgotten here? What has been forgotten here? I've done the anterior, I've got the aesthetics, I know what I'm going to do, but what have I forgotten? Yes? Well, I take you to a litigation case. So I was expert witness on several cases. I served on the General Dental Council, I served on disciplinary committees, all kinds of stuff. Yes, I worked for the Lord Chancellor, for 18 odd years, being one of the three wise men to help appoint judges and magistrates. Yes. So litigation and the law is part and parcel of what I know. And hence, that's what I will finish on at the end of this lecture as to what you need to watch out for. So this was a case. The patient was sent to me because the patient was unhappy with her teeth. When I asked her, what is it that makes, so the lawyer sent it. So I asked her, what is it that you're unhappy with the teeth? Is it the appearance? She said, no, it's much better than my previous teeth. Is it the color? No, it's much, but there's something wrong. There's something wrong. I don't know what is wrong. And of course, if you've just heard my good friend and colleague, Professor Ziad's lecture, you realize what it was. The anterior guidance was changed on that patient. The patient's teeth are not just about occlusion, it's also about disclusion. The anterior guidance was missing. So this is my car. And in fact, it looking very pretty outside my house does not matter as much as how it functions. Looking pretty alone isn't enough, because if it doesn't function well, you'll be having some people to tow your car away. Yeah? You need both aesthetics and function. And in occlusion, it's function and dysfunction. It's occlusion and disclusion. Occlusion is the bringing of teeth together. That's done on verticulators. Disclusion is what's done on articulators. It is taking that, and you may not understand the significance of it, because a lot of occlusion is built on lies. We will explain to you and teach you why these things matter and whether there is any science behind it. I can tell you there isn't much science behind it, but practically speaking and legally speaking, it helps a huge amount. So it's a bit like this. A mandible is like a three-legged stool. When you put an anterior deprogrammer, yes, it moves like a three-legged stool, and that's how you find centric relation. Centric relation is a bad position. It's an artificial position. You don't want it, but you want to relate to it. And when you close, it's like moving the three-legged stool back to its original position. So that's the concept that most people don't understand, including academics. And we will teach you to understand it, because once you do that, you find life different. And once you understand where disclusion is, you want to capture it. The most important part of an articulator is its incisal guidance table. So here's one of my patients where the disclusion has been captured on a incisal guidance table with Durelay, as explained by Professor Ziad. Yeah. Posterior stability and anterior guidance. That's the story of occlusion and disclusion. Mustn't forget it. It is so important. Manufacturers have pre-planned this as well as mechanical alterable tables. So this is KVOs. So I actually was with Walter Lang when he was inventing the Digma. And I contributed to some of the thinking behind it. It's a 4-dimensional Facebook record. It's totally different from an arbitrary Facebook. We have one at the College of Medicine and Dentistry, Digma 2. I had the Digma 1 because, of course, I was part and parcel of the original bit of, let's say, understanding of it. So this, of course, is the traditional anterior guidance table, whereby you put in a bit of acrylic and then you move it around, capturing the anterior guidance. And then when you do your final work, you copy the anterior guidance back in reverse on the palatal surfaces of the anterior teeth. Because, of course, the patient wasn't susceptible when the patient came. The patient had no occlusal problems. The fact that you allowed the technician to build the disclusion with no prescription meant now the disclusion was an interference for the patient. And the patient was never happy. Now, KVO, for example, this is a table, that's the incisal table on which you do this. See? And it's a reusable table because you can flick it out afterwards. After you've done it, as long as you've Vaselined it, you can flick it out. And then each time the patient comes back, you can slip it back on and reuse it. But there's a screw at the bottom. The screw base at the bottom actually has, at the base of it, an arbitrary anterior guidance table. And in fact, if you ask KVO, they'll give it to you at different angles. They'll give you this screw at different angles so that if a patient didn't have anterior guidance, anterior disclusion, if you were going into the provisional phase, remember what Ziad said, Prof. Ziad said, yes, it is not a temporary phase, provisional. Provisional means you're learning from it. We don't do temporary crowns here. We do provisional. We want to learn shape, color, aesthetics, function, dysfunction. So we place this. So if you had nothing to start from, without having to find a kinematic Facebook like the Digma, you can start with an arbitrary anterior guidance, yes, for that patient and build on it. And in fact, this is KVO's own, the Protar's own incisor guidance table, where you can actually change the angles without needing this. So you can have it at any number of degrees. And this is Dina's, which I also have. Yes, I've had the Dina pantograph, the Pantronic, the Sam axiograph, the Digma, the lot. Yes, where you can change the anterior guidance. And you can also create long centric. You can also create long centric on this. Yeah. So manufacturers know, dentists don't know. No point buying all this stuff if you don't know how to use it, because the condylar guidance is actually an interference. It's an interference. You need to know facebows are bad for smile line analysis. Facebows are contraindicated for aesthetic dentistry. You need to understand it. We will teach you those things. And in fact, here you are. I will show you. Now here you are, you've got anterior disclusion. But look if a patient has reduced condylar guidance. Yes, when the patient has reduced condylar guidance, reduced anterior guidance, ends up with posterior interference. So you need to know what this is in relation to this before you can undertake the treatment on this patient. So I come to a different case, severe tooth surface loss, a youth spent with misused drugs and all kinds of things. And that's what she was in her teens. And very soon she went around like this. And we are, of course, going to reconstruct her somewhere along the line. And those are the teeth. And what I do when I have time at lunchtime is, all these old composite that you have which has expired. Everybody has expired composites, don't they? Yes. I mean, when manufacturers sell you a box of composites, you have shades that you will never use even on a monkey. And of course, they've all expired. What do you do with them? You can't send them to the third world. They've all expired. So what people like me tend to do, because I know composites are metameric, yes, have a chameleon effect, is that I use these and I do my own diagnostic backside. So I sit there, and usually it's my nurse who sits next to me, and she's with the zap. She goes 2 seconds zap, 2 seconds, and it's all done with a scalpel. just like in that other patient in the mouth. Yes. And then what you do is you make a quick pull down template. You don't even have to make plaster models. You do a quick pull down template. And when you show this to the patient, put your thumb over it. If you put your thumb over it, the shadow will make all these colors blend together. So remember, this patient has tooth surface loss, which is very severe. I built it up with composites, just scalpel blade and all composite expired stock. Yes, because that's not going into the patient's mouth. Yeah. And then when I show it, I show my thumb over and the patient, oh, that looks all right. That looks all right. Looks like my picture. And then I make a pull down template. Yes, a suck down template on that itself, because I don't need to make a plaster cast. And then I fill it full of composite, stick it over the patient's teeth, no acid etch. Use a scalpel to just trim off the excess. Couldn't care less what the margins were like. Tell the patient to go home. Yes, take it home and try it out. It'll fall out. But when it falls out, the impact is so dramatic because they say, what's happened to your teeth? What's happened to your teeth? Yep, they'll want it fixed. I can tell you, they'll want it fixed. Of course, on that first day, I also made an arbitrary mock-up. And so when the patient comes back, I'm going to do it provisionally because I'm going to do fixed work on the patient. Yes, I know my colleague who started off, Professor Mehta, was extremely gentle, kind, and so on. But I'm on the last train home with the patients in their last stage of life. Can't faff around. They can't go into care homes and end up keep coming back to see me. So I'm cut and thrust. But I go through the intermediary phase of plastic restorations from which I learn and then I replace it. Yes. So here you are. So this is my quick fix. Doesn't take much time. I use a silicone index. And what do I do? I build up the aesthetics. Lamella built up. It takes no time at all. 5 minutes a tooth, max. Then palatally, I don't use composite. Composite is a nasty material. It's lovely aesthetically on that day. It hydrolyzes, it breaks down. It's also a petrochemical product, which makes it a known carcinogen. That's why it kills pulps. Don't put it near pulps. But nevertheless, it's very pretty on the day you put it in. But it's also made of sandpaper. Composite is resin and filler. Filler is sandpaper. What's the sandpaper you use to sand your walls, to sand your car, to sand your shelves? Same stuff as composite. Resin, filler, resin and sand. This is man-made sand and resin. So composites, so therefore in patients who are clenching parafunctionists, composites are bad material to even build up teeth because it beats the living daylights out of the opposing tooth. So if you're putting composite, put it against composite. But most people parafunction, so it's not a problem. Parafunction is universal. Pullinger, Seligman and Pullinger produced that paper back in the 1990s. And Pullinger and I have lectured together across the world. And as he says, it's common. It's parafunction is natural. It's a good thing. It's a stress relief. Much rather parafunction than kill your partner. It's when you clench and parafunction, it becomes different. That's a different kind of occlusion, a different kind of reconstruction. And you need to come to us for us to teach you how to undertake clenching parafunctions. In the meantime, in ordinary parafunctionists, because everybody parafunctions, you don't want to put composite on the palatal surfaces of discluding teeth. Because discluding teeth protect occlusion. Occlusion protects disclusion. Back protects the front. Front protects the back. Disclusion protects occlusion. Bang, bang. So if you're going to have disclusion, you don't want it to start wearing the opposing tooth. So we use something softer, a bisacral, which can bond to composite, or a compomer. So we place on compomers for the palatal, and then we let the patient go home and function on it. We just leave it with the patient. So now we wait and wait and wait. If it keeps falling off, we know we haven't got the occlusion right. We haven't got the disclusion right. So we go and make some adjustments. I'll show you lots of cases for wide centric, long centric. Yes, the really complex ones. Yeah. So we allow the patient to work it out by themselves on their own time instead of our time. And once they have now created their disclusion, everything is good. We then take study casts of our temporary work and we construct the anterior guidance table. Now we can go back and copy the final crown and bridge work to this. So remember, don't forget disclusion when you do aesthetic dentistry. But that's not what my lecture is still about. It is part, it's the middle way. So I'm telling you, aesthetic dentistry, if you're going to go down that route, and that is what you have marketed yourself as, don't forget function and dysfunction. Being pretty alone isn't enough. The patient must not come back and sue you for something nobody understands. And what else have you forgotten? My good friend and colleague, Professor Ziad, hadn't forgotten. It's fremitus. All teeth will have fremitus. Why do you have fremitus? Fremitus you have fremitus. So that is when you put your finger on your tooth and you bite together. All of you, if you put your finger on your tooth and bite hard together, go tap, 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 tap on your posterior teeth, you'll find your front teeth move. And the reason for that is because of not just differential mobility, but adaptive mobility of the teeth. Teeth can be intruded by almost 60 microns. So you have 3, 4, 5, 6 shim stocks worth of movement. You can have that much movement of the lower teeth hitting the upper teeth. And that's why for veneers, on patients who are parafunctionists, who have moving teeth, and everybody's teeth move, they move between 20 to 60 to 80 microns in 3 dimensions. Imagine, just think about it. Veneers are stuck on the front of the teeth. Why do they fall off? They're not in occlusion. They're not in disclusion. The reason they fall out is because of the judder on them. The judder on them. The fremitus on them. When the fremitus hits, the veneers are stuck on with only micromechanical retention, tiny bits of retention on the retipegs. And usually you're putting veneers on some other dentist, stupid veneers, where he's removed all the enamel. Only enamel has the retipegs. Dentine does not have it. There is no dentine retention. When you come to adhesive dentistry, you realize dentine has no bonding. Dentine bonding is a fudge. And a lot of the many generations of bonding agents are there to reduce your time and effort. And it's very good for most patients because most patients are okay. It's like parafunctioning. Everybody parafunctions. It's like plaque. Gingivitis is common to everybody. It's not a big threat. Periodontitis is totally different disease to gingivitis. Totally different. It may not even be due to plaque. But that's a different lecture for another day. So like that, same again with fremitus. If you don't have enough enamel, you don't have micromechanical retention. Your veneers will keep popping off. So that's why you overlap it palatally. So you end up with macromechanical retention. To get micromechanical retention, the composite must shrink to lock against the retipegs. That's the retention. The retention is mechanical. It shrinks and locks. It locks into the tiny enamel retipegs. That's why you don't etch for more than 10 seconds, 15 seconds maximum. Because if you over etch, you've left too many dead spaces and then the bad color gets in from your coffee and tea and it looks terrible. So you etch sharp, etch flash, bond quick. But of course, if you don't have any enamel, you can't rely on dentine. Dentine is rubbish. It doesn't stick. The whole idea is to not allow it to push the composite out. That's why you have wet bonding. And because dentists don't know how much wet is wet, they incorporate the wetness into their hydrophilic monomers. Yeah, it's all very clever stuff. Yes, to try and make their product sell. That's why you wrap it over. Once you wrap it over, there's micromechanical retention of the enamel retipegs locking, but there's macromechanical retention of the entire composite locking. The entire adhesive locks on itself. And that's the reason why you lap over the incised ledge. Huh? See? Free lectures. Come and learn the real things. So, but really, at the end of the day, go and find the best technician you can't afford. And you create a career with that person. I was very lucky. My technician came from the Lebanon, Nadim Kurban. He was Peter K. Thomas's own technician. And most of the work, if not all the work I show you, will be Nadim's. I just take the money. So as a dentist with a team on song, you need the right information regarding the smile line, good study cast, gingival tissue control, sound tooth preparation will teach you to cut like gods. That's if you come to the crown and bridge section. Of course, Shamir will teach you the adhesive part of it, and that'll be brilliant because he's brilliant. Yes, and Ziad, we all know is already brilliant. Yes, and of course the functional prescription of pathology with Ziad as well. Yes, diagnostic provisional, see, not temporaries, chair-side characterizations, patient participation means we talk to the coconut of the patient, correct selection of materials placed correctly, and we'll teach you about all the different materials, why some are rubbish, some are not. But we have to use rubbish in some circumstances, whether we like it or not. It depends on who that patient is. You know what the problem is, it's who the patient is. The who the patient is far more important than what is the problem. And you need an excellent citation, but that's still not enough. That, I'm afraid, is still not enough. So what's missing? This is the paradigm shift. The world has changed, certainly in the West. It's a major change in how people think and get things. Yes? We can't sell origami when patients expect a swap. The game is changing. I should know. I was at the forefront of seeing all these changes happen, thinking, oh, by the grace of God go I. I could have been there. I could have been there. Aren't I lucky? So, really, silence does not equal consent. Consent in the Western world has to be informed and understood. But that's not all now. I mean, we know that, but it's more complex than that. Yes? You see, the legal framework has completely changed because there's new law coming in. It's all about previous case law. And the case law is changing rapidly all the time. Now, I'll bring you up to date with it. And this is Paul Tipton, a very fine dentist, who said dentists are seen as easy pickings by the public and solicitors. And there's been a phenomenal rise of dental negligence cases. So much more litigation. A lot of the time you look at it and you think, gosh, it's not that bad. But yet, it's not very defensible. We got to pay up. And once you start paying up, defense societies will charge you more for your indemnity insurance. And it's a mandatory requirement in the United Kingdom and many of the Western countries to have indemnity insurance. And sometimes it can go into 30,000, 40,000 pounds a year for people who have not perhaps because they have intentionally made a mistake, but have made a mistake that they maybe shouldn't have. The old test, the Bolam test of 1957, that was due to a person who needed to have shock therapy because he was mentally unstable. And the doctor who gave the patient shock therapy did not tie the patient down on the chair before the shock therapy was given. So when the shock therapy was given, the patient flew off the chair, hit the floor, broke the hips, sued the doctor. Case went to court. Court said, ha, 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 ha. Doctors are always right. Just because some doctors might tie you in, it doesn't mean every doctor has to tie you in because some doctors don't tie their patients in. It's your fault for jumping off the chair and breaking your hip. I'm afraid that era is gone, finished, over. We got a shock when the next era came, which was the Huxon Code in the Court of Appeal. And there it was said the courts must be vigilant to see whether the reasons given for putting a patient at risk are valid in the light of any well-known advance in medical knowledge or whether they stem from a residual adherence to out-of-date ideas. In other words, if you felt you didn't have to tie a patient in, when the knowledge said you did have to, then I'm afraid you're stuffed. But it took almost 10 years, more than 10 years, for that to come about. But that's not all. The Bolito case came. And the Bolito case came in and said, excuse me, there may be a body of opinion which is saying this. There may be another body of opinion saying this. And both bodies of opinion, one from the Royal College of Surgeons of England, one from the Royal College of Surgeons of Edinburgh, well, aren't they Royal Colleges of Surgeons? Aren't they from England and Edinburgh? I mean, I was a dean at the Royal College of Surgeons of England at one time. Yes. Who is right? Of course, I would say I'm right because I'm from England. Edinburgh would say they are right. But the judge said, no, the body of opinion must also be shown to be reasonable. And who decides that is the question. And the decision is made by the man on the Clapham omnibus. It's not made by the profession. We take professional views. I'm sitting from the Lord Chancellor's chair, the judge's chair. We take the views, but the decision is mine, or it's the decision of my jury. They must think which opinion was better. Oops. But it's moved on even further than that. Huh? This is James Garner and Doris Day. You won't even remember them. They're probably dead before you were born. Huh? These were in my time. Move Over, Darling was a lovely movie. The Montgomery in 2015. It was all about medical paternalism. In other words, it said doctors really cannot talk down to patients. Patients are autonomous. They have freedoms of independence, of choice. They should decide for themselves with all the information provided. So this was against the Lanarkshire Health Board. And what it actually said was, patients must make the decision. A reasonable person, a patient is considered a reasonable person. A reasonable person in the patient's position would be likely to attach a significance to the risk, or the doctor is or should be reasonably aware that the patient would be likely to attach significance to it. So you need to tell them almost all the risks that a patient might consider significant. So now you can't turn around and say your tooth might die because I'm using a composite. I mean, nowadays you can't turn around and not say your tooth might die because I'm using a composite. You will say that because composites are petrochemical products. They are known mutagens, they are known carcinogens. That's why more bacteria grow next to composites than they do against amalgam. Amalgam is micromercurial poisoning. Amalgam is not adhesive. There's always a gap between amalgam and the tooth. But amalgams leak a lot less than a composite. Why? Because no respecting bacteria is going to grow up their children under a micromercurial toxic time bomb. But they love composites because composites are petrochemical products, and that's how evolution takes place. You have a mutagen, your children are going to have 3 heads and 5 hands. Isn't it wonderful? Far more attractive kids. So that's why most composites, once they start fracturing off the adhesion bit, are something where bacteria love to breed. Yeah. So you should be able to turn around and say, these are actually toxic to the pulp as well. And when you come, we'll teach you about the pulp, how the pulp defends itself despite you. And why it is you use an air rotor and not an electric micromotor to cut teeth. Now that's interesting too. Why buy an air rotor when you can buy a cheaper micromotor going just as fast, but you don't cut teeth with that? Wow. Then the Muller case, the last I will show you. There are others in the pipeline. And this is against King's College Hospital NHS Foundation. But they turned around and said, you can't take an overview like that. You have to break it in 2. You have to take it as a diagnostic question. First, you must find out whether it was wrong at the top. Then you have to decide whether it is wrong at the bottom. Double jeopardy. So the first type is when a patient's condition is unknown and the diagnosis is either right or wrong. If wrong, is it negligently so or not? And this was to do with some histological work that was done. The second type is a pure treatment where the nature of the patient's condition is known and the alleged negligence consists of a decision to treat or advise treatment of the condition in a particular manner. In other words, it's a 2-step process now. So whether the medical practitioner acted in accordance with the practice accepted as proper and ordinary, competent medical practitioner by a responsible body of medical opinion, which is decided by an individual who is not a medical person, and whether the practice survives Bolito's judicial scrutiny of being reasonable and responsible. Whoa, that's a change in life, isn't it? So I'll show you a case. This is not mine. Picked it out of the internet, and I show it to my students. And this patient came for aesthetic improvement, I believe. Yes. And I show the work that was done. And it really does look nice. I mean, no, it's enviable. Yes, I mean, there's a bit of gingival inflammation. And one of the reasons you have gingival inflammation is if you're using adhesive dentistry, the adhesive leaches out from behind your veneer. That leaching out from behind your veneer hits the gingiva. Some patients' gingiva are more sensitive than other patients' gingiva. And that's why you have persistent inflammation after you've cemented adhesive dentistry. Adhesive dentistry, if you're going to cement anything with adhesive dentistry, make sure you put a barrier on the gingiva so that if it's a retraction cord, which is very lightly placed, that picks up all the adhesive and you whip it out. Make sure you polish the margins well from the adhesive, because as long as the adhesive is there, you can't see the adhesive. It doesn't stick to the dentine. So because it is gingival, and it is root surface, and it is cementum. It can't bond to the cementum, but it overlays the cementum with small adhesive bits, a bit like Velcro. And inside these Velcro bits will be the bugs. They can grow there. And the Velcro itself is an inflammatory material. Composites are inflammatory. Yes? Next time you have a cut on your finger, put a bit of composite on it. Hurts like mad. Nasty product. Composites are high allergens. They go through gloves to produce the allergy. So you want to make sure that the gingiva is well protected whenever you use adhesive dentistry. Because if the material gets underneath there, it's a big problem. Because the gingiva can't heal very well. Now, I showed you the before, I showed you the after, and I said they were lovely. My students all think they're lovely. Now let's show you the intermediate slide, the one in the middle. Now, what do you think? Now, if you showed that to the patient or the patient's family, would they have approved of this? When really, your colleagues would have turned around and said, why don't you just add a bit of composite here? Pop the inside little and send them to Wyman Chan. Get Wyman to get the teeth white. Our Professor Chan is a miracle man. And you just add a bit of composite. Send it to Professor Shamir. Done. You don't even have to send him to Professor Ziad, because of course you haven't changed the palatal occlusion at all. Yeah. Now, what do you think? Now, this is a potentially serious litigation case. You can turn around and say, oh, I don't have this cast. I don't have. You need to. Baseline records are compulsory, are mandatory. If you're going to treat a patient whom another person might think is harmful, you needed to have had the evidence to show that you hadn't. In the absence of it, well, whose word is going to be taken? Here is Martin Kelleher, an old adversary of mine, just retired from King's, one of the finest pairs of hands in dentistry, one of the most brilliant speakers. If ever he can, if you ever come across lecturing, him lecturing, please go and listen to him. Outrageously funny, marvelously practical, and shows superb work. And he said, and this is in the journal published by the Royal College of Surgeons of England, which is very close to my heart. That's the Faculty of Dental Surgery's journal. He said, the blatant destruction of teeth apparently are being undertaken to cure patients affected by porcelain deficiency disease. I mean, what a powerful statement. Why are you removing sound, good enamel, Raj? He said. Do your patients suffer from porcelain deficiency disease? Why do you want to replace good enamel with porcelain? Is that a disease? He went on to say this is a newish disease identified by some dentists who also seem to think that teeth suffer from hyperenamelosis, an excess of enamel. It's a new term coined by him, hyperenamelosis and porcelain deficiency disease. He wanted to say, it probably goes without saying that both of these conditions are imaginary, fictitious. Yet it appears to me at times that they are perceived to exist by some cosmetic dentists. Now he sits on the board of our largest indemnity society, the Dental Protection Limited. Double mugging of these patients. These unfortunate patients are being robbed twice, first of their money and again of their enamel and dentine. So if you are coming to Britain to work, take heed of what I am saying. And we will teach you that. You may turn around and say, but the patient insisted, the patient wanted it, the patient swore they will not sue. Here's a patient, here's a fictitious patient who came and said, my daughter is getting married to a prince in 10 days' time. Can I have great teeth for the wedding, please? And you look inside the mouth, and this is what you see. And you say, oh, no. She says, no, I don't want dentures. It's 10 days. Just put bridges in there. I know they will fail. I'll lose my teeth. I will sign any indemnity. And she signs, I know my teeth will fall out. I've insisted that you undertake the crown and bridge work. I am happy to pay for it. Here is the money up front. Please do the work. I absolve you from any litigation. Witness, signed, sealed, handed over. Doesn't work. And doesn't work. patients cannot write away their rights. It's a bit like buying something from John Lewis, one of the best department stores here. And they say, I'm afraid we can't give you a guarantee on this because it is something in the showroom. I'm afraid if it fails within 1 year, you still have the guarantee. You cannot sign away the guarantee. If you're asked by a patient to undertake treatment that you believe is unnecessary, you must act in the patient, because only the patient doesn't know, only you know. Only you know. And the patient will come back and say, my bridges have fallen out. It's only lasted 3 weeks. But I said, I did tell you it won't last. Ha, 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 ha. What do you mean? You signed an indemnity. That's not worth it because I didn't know all the reasons. Yeah. Do not undertake treatment that will cause permanent damage to the dentition or will be of no clinical or cosmetic benefit. This is after work from people like Professor Aubrey Shyam, Professor Richard Elderton, and all of the others. They turned around and said, people who didn't go to see a dentist regularly ended up with more teeth than people who went to see dentists regularly. We were the harmful people for patients. If the treatment fails, the patient may seek damages. And finally, a signed statement from the patient instructing you to carry out the treatment and absolving you from any of the stated adverse consequences may not provide a valid defense in the court or before the General Dental Council of the United Kingdom. So times have changed. You will need to practice defensive dentistry. And defensive dentistry is not a bad thing. It is not against the patient. It is to protect your reputation. And if you are a student of our College of Medicine Dentistry, our reputation, because our reputation will lie in your hands. And therefore, we have an interest in protecting you, and you must have an interest in protecting us. The world, certainly in the West, has changed. It has become far more litigious. And I would tell you without any hesitation that you will need to think when you put yourself out as a cosmetic dentist of all the consequences, not just aesthetics, not just function, but also how it will stand up to scrutiny. So therein lies not one paradigm shift, but several when it comes to the care of a fellow human being. I hope it's been food for thought. I'm allowed to be outrageous, but I'm not. It is what it is. Well, I hope I get to see some of you at least at the college at some point in time. And I hope you've had a very good conference. Thank you very much for having listened in.
Thank you very much, Raj. That was as entertaining and enlightening as always. I always really enjoy hearing you speak, I have to say. Has anybody got any questions for Raj that they could put in the chat box?
Any questions? I can't find my chat box. You'll have to read it out to me.
No worries. Nothing's come up yet. Somebody's thanking you for your great lecture. Thank you for your much energetic presentation.
I can tell you at my age, if it wasn't energetic, I'll probably be dead.
Any questions for Raj, anybody, before we let him go?
Well, all it leaves me to say is thank you all, guys. And I hope you have a wonderful, great, and superb career.
Thank you very much, Raj. No doubt I'll see you soon.
Cheers.
So thank you, everyone, for today. I think it's been a really informative and excellent day. I've really enjoyed it myself personally. If you do want any more information, obviously you can contact the Knightsbridge Academy at info@kbac.uk. For any information on the courses from the College of Medicine and Dentistry, it's a similar email address, so info@comd.org.uk. So if there's any questions or any further questions from that, just email either of the email addresses and we'll be able to assist you and get them answered for you. I think that's it from us. Is there anything that you want to say, Bulent, before we sign off?
No, thank you very much, Andrew, for your effort, for your great introduction.
Thank you.
See you next time.
See you next time. Thank you, everyone.
Thank you. Thank you for everyone.
Thanks.